All right, ladies and gentlemen, it's 10 o'clock. Time for the last class of the year. I want to thank Chris Barbour for coming out and presenting our third in our series of pediatric classes. Just trying to cover some of the PALS stuff out there. And Chris is going to cover pediatric shock management. Uh, and I will turn it over to Chris and thank you all for coming out and happy holidays, Merry Christmas.
Thanks, Tony. Um, for those of you who don't know me, Chris Barbour, I am the program director for Air Evac out of Grant County. Additionally, I am a PALS instructor. I've been teaching PALS for probably 8 or 9 years now. And I'm also an ER nurse, so don't hold that against me for my EMS folks. Here's a little disclosure about me. Oh, wait, objectives. I missed the disclosure. It's fine. Here are our objectives. I'm not going to read them to you. You all are adults. We're going to go over pediatric shock, how to assess it, how to treat it, and what it is. No good lecture is not without a A&P review. So when we talk about shock, the main systems that we're talking about is the circulatory system. So we either need the heart to pump the blood, the veins and the arteries to carry said blood, and we need the blood. Without those things, we will go into shock. So a little deeper into the cardiovascular function. We need to have the amount of blood pumping per minute. So that's where cardiac output is going to come into play. Our heart rate versus our stroke volume. If your heart cannot adequately move the blood around, then you're going to have a lack of oxygen and nutrients to the cells. Children will kick up their heart rate in response to this, mostly because their left ventricle isn't strong enough to increase the heart's push of that blood through the system. The lovely preload, afterload, and contractility. Don't worry, I'm not going to go into Starling's law of contractility. Maybe a little later. Volume returning to the heart is our preload. So if we have something pushing against our vena cava, we're not going to get the venous return. If we have something blocking the other side on our arterial system, we're going to have the resistance of our afterload. So we're not going to be able to get it out of the heart. And then our blood pressure. I think we all understand what blood pressure is. Children will maintain a normal blood pressure until the end. So hypotension, you're going to hear me say this a few times, is a very late sign in shock for a child. There is one other part of this. We have to be able to move oxygen around. So when we talk about perfusion and oxygenation, we might be able to oxygenate the lungs, but can the heart move that oxygenated blood around? And this is just a little bit of the A&P behind it. Just remember that if there's a break in any of these lovely things down here, you will get tissue hypoxia and you'll go into shock. If it's too prolonged, you'll start to end up with an acidosis, and you may get up into a state where you're going to start having organ death and then death of the patient. Without the oxygen flowing through the system, the cells switch over to an anaerobic metabolism, and that's where the lactic acid will build up. So here's some differences between the kids and the adults. Like I said before, kids will typically go into um, a tachycardia when they have some sort of shock. If you see a child and they are bradycardic, it is an ominous sign, or it is a sign of a different kind of shock than we're typically treating. And we'll talk about that more later. The blood volume of a child is, as you can imagine, much less. So if we were to say lose 200 mLs, we are at about 25% blood loss depending on the age of the child. If you think of 200 mLs, I mean, we give adults a bolus that is 5 times that much when we're seeing an adult in shock, and that's just the starting bolus. Children breathe faster, so they're going to consume more oxygen. I think that one is pretty well stated, is depending on the age of the child, they're going to either be rapid heart or rapid respiratory rates from the start. As they get older, those decrease. So the children have a very great ability to vasoconstrict and maintain. And this will mask that shock state. So we're really looking for the other signs of shock with these kids. Finally, one of the things that kills trauma patients, as I think we all know, is if they get cold. So hypothermia is a real thing for these kids, especially because they have a larger body surface area compared to their weight. And depending on how old they are, they might not have the fat to keep them warm. So let's define shock. The textbooks and dictionary will define shock as a state of inadequate oxygen and nutrient delivery to meet the metabolic demand of the cell. Well, that's a very great book answer. Usually what that means for us is there's something impeding us from moving the blood through the system, or the system has gotten so large that we can't move it around. So here we have compensated and decompensated. If you look at some of the newer texts from the American Heart Association, they've changed decompensated to hypotensive. So compensated, you're still going to see signs of perfusion. Signs of poor perfusion are present, but the blood pressure maintains normal for that patient's age. This is where we want to intervene. We do not want these kids, as the title may have suggested you, the phrase we always use is to fall off the cliff. They get to that point and then they are decompensated. So all of their compensatory mechanisms are failing, and now you have signs of poor perfusion and hypotension. By this point, we're kind of chasing them, trying to get to them before they go into cardiac arrest. So recognizing the shock and treating it early is what we're trying to go for. So here's some of the compensatory mechanisms that we look for the patients to be doing to maintain their blood pressure. And this is going to be for a healthy patient. So our heart rate is going to kick up. The baroreceptors in the carotid artery and the aortic arch detect the falling blood pressure, and they start to constrict. So we start to get that heart rate increase, and we start to get the vasoconstriction. The contractility kicks up, especially once the child is older or in an adult, because they have the ability for that left ventricle to start really kicking in. So here's the signs you're going to see when the contractility starts. When we have bounding pulses, later on in the progression of shock, they're going to get weak. When it comes to the vasoconstriction, there are signals that are sent from the baroreceptors to the brain, and that starts all of this kicking off. So we get the constriction of the blood vessels in the skin first, and then it moves to the GI tract, the kidneys, and the extremities, and we all start to shunt blood to the brain and the heart. As a assessment tip, what I am looking for with this one is I will check a peripheral pulse and a carotid pulse at the same time. That'll real quick tell me if we've already started to shunt, because the pulses may not feel the same. Vascular resistance, if we see the cold extremities, the pallor, the refill is getting slower, weak peripheral pulses, or we are not going to see decreased urine output. That's an ICU thing, but those are the signs. And then your respiratory rate. This is going to probably be done for some sort of acidosis that starts. That lactic acid builds up, and the body's easiest way to get rid of it is by changing the respiratory rate. I've seen lots of crews when we do simulation and the patient's respiratory rate is super high and they want to take over breathing for them, and they want to do it at a normal rate. If your patients are already tachypnic, you need to ask yourself, why are they tachypnic? And do I want to slow them down, or should I let them keep breathing at this rate? So what happens when this stuff fails? Kids will keep going and keep going and keep going, and then they stop. So you have progressive tissue hypoxia, which is what I was talking about with the lactic acidosis. Your heart will start to lose its contractility as that acidosis builds up. The smooth muscle, they start to die off, and your BP drops. Once you get down here to the end, you're going to see somebody who's going bradycardic. If you have any shock patient, whether it's adult or pediatric, seeing them being bradycardic should really raise your awareness of what's going on. The one thing I'll say about bradycardia in adults specifically, if you have a patient who's bradycardic as an adult, you may want to look at their med list to see if they're on a beta blocker. Those patients might not have the ability to kick up their heart rate due to their medications that they're on. So here are some of the signs and symptoms of shock. I think everybody who's ever taken PALS or any lessons on shock knows that the typical stuff is going to be a tachycardic, tachypnic, they may be cold or pale, low blood pressure, and then you may have some other signs of nausea, vomiting, or thirst. Those we don't typically see early on, but those are the progressions. The ones we want to be really concerned about are the altered mental status. In a kid, the hard part about figuring this out is the kid drowsy because it's nap time, or are they drowsy because they're in a shock state? If you see cyanosis, that's definitely not a good thing ever. All right. So please forgive me for my attempt at using Gemini to help me create some more interesting pictures for you to look at. I like to think of shock as a plumbing problem. So if you think about it, you have a pump, which is your heart. You have your blood vessels, which is your pipe. And then you have your blood going into those to move around. If we break one of these, we're going to have problems. So there's 4 types of shock. The one we're probably most common with, especially those of us who are older paramedics, is this one. You have your hypovolemic patient. The traditional PALS scenario years ago was a 3-4-year-old who's had nausea, vomiting, diarrhea for 3 days, hasn't been able to eat or drink. You respond and they are lethargic and mottled, and you have to treat them. So just remember, you can also have hypovolemia from blood loss. If they've lost blood, we need to replace it with blood if we can. If they've lost fluids, we need to go with fluids. Distributive, this is where we've made the tank too big, like an anaphylaxis. Cardiogenic, pretty obvious, it's right there in the name. There's something going on with the heart. And then obstructive is the one that people seem to forget about when I do this class at Children's. And that's going to be typically due to some sort of trauma or some other sort of blockage going on. So let's start off with hypovolemia again. So we have a volume problem. Do we need to give fluids? Do we need to treat a cause? So here are some common causes for hypovolemia. We don't have the volume, so we decrease the preload, which decreases the cardiac output, and that's where we get our inadequate tissue perfusion. So we can control bleeding, we can give fluids. The traditional treatment for a child is going to be a 20 ml per kilo fluid bolus. That changes with our cardiac patients, but we'll see that in a minute. If we have somebody who's got some sort of vomiting, diarrhea, DKA can cause kids to really lose a lot of fluids. We can place them with fluids. Assessment site here on infants, that sunken fontanelle that we look for. Everything else should be pretty close to what you would see in an adult. In these cases, these kids may end up needing 40 to 60 mLs per kilo, but we don't want to necessarily give that all at once. We'll get to that more later. So distributive shock. And I just saw that AI screwed up the spelling of distributive. All right. So distributive shock, you have the massive vasodilation, which seems to be hypovolemia to the body, and the blood flow is distributed in areas that it can't use. So now we have poor tissue perfusion. I think the two that we are most familiar with this would be sepsis and anaphylaxis. Sepsis, I think we're doing a much better job in EMS than we did years ago. That's why I put on here early recognition is critical, and notifying the receiving facility earlier is critical. That can start all of the things that need to happen once they get there. There are some jurisdictions which are going ahead and administering antibiotics in the field for sepsis. I don't know of any that are doing that for pediatric patients, however. Typical signs. This one, if you've never been exposed to meningitis, if you see it, you probably want to put on a mask, or you're going to end up getting antibiotics. Sepsis in some of these kids, when I've talked to the children's ICU folks, they've said that there have been kids that have gotten close to 80 mLs per kilo of fluid. Their policy is after they've given 60, they will go ahead and start them on a presser. It used to be in kids that the presser that was used was epi. Now it depends on the patient. They're using more levofed, vasopressin, and they still use epi dependent on the patient. Anaphylaxis. First line treatment is going to be epinephrine, IM. The funny thing about teaching doctors at Children's is that they get to tell you the reference dose of epi is what they would give. Well, that's great until you have somebody looking at the PALS card and there's 5 or 7 different doses of epi and they have to pick one. So your auto injector is going to be the other way to do this. This is just your regular dose. The auto injector is going to be 0.15 to 0.3. You can also consider the steroids, the dopamine, or excuse me, the Benadryl, diphenhydramine, in there. The one we don't think about very often is neurogenic. In all the years I've done this, I've only truly seen 2 patients in the field that were neurogenic, and neither of them was a child, though one was only like 20 years old. If you have any suspicion of an injury to the spinal cord or high thoracic area, you're going to want to possibly look at this. You're going to have hypotension with bradycardia or a normal heart rate. They're not going to be tachycardic. Flaccid limbs below the injury, and in males, you may see a priapism. These patients are going to need to have some sort of pressor used, typically more so than fluids. You'll give the fluids first, but there may not be any help. You need to get them to a trauma center as quick as you can. Cardiogenic. So now we have a pump problem. See this a lot at Children's with kids who have some sort of cardiac defect going on. And that tends to be what people think about when you think of cardiogenic shock. You can have cardiogenic shock due to your heart rate being a problem. So your SVTs, your VTACs, your extreme bradycardias, and heart blocks. This is something that especially in EMS, we're pretty good about fixing and knowing what to do about it. So I won't go into that too much. I think everybody knows how to treat a patient who's having some sort of cardiac rhythm problem. The ones that we don't think about are the viral infections. So your pericarditis, myocarditis patients. Those may be the patients that present with just an illness and chest pain, respiratory distress, and fatigue. And you're trying to figure out what's going on with them, and we may start treating them like they're septic. If you start dumping a bunch of fluid into these patients, you may end up with a patient in fluid overload. That's why I point out myocarditis is something to think about. The kids who have an unrepaired lesion, been at Children's for 10 years, and I know of one child who presented to the hospital. They were minimal prenatal care, healthy baby at delivery, normal delivery, no problem. 2 weeks later, came back, limp, blue, coding. They coded the patient for a while, and the inevitable question came out from the person doing the team lead. Does anybody have any other ideas? And a resident actually threw out the idea of the ductus is being closed, and they had a ductal dependent lesion. The treatment for that is prostaglandins, not something we carry in the field. But if you were to have a baby that presents like this, you may want to try and get them to the closest facility that can administer prostaglandins. I know that they can do it at Edgewood. I know they can do it at UC and Children's. The rest of them, I'm not 100% sure. Big thing for cardiogenic shock when we talk about it is to use smaller boluses. So we're going to go to 5 to 10 mLs per kilo, and we're going to give that to them maybe a little slower than we would depending on what their blood pressure is. We want to listen for lung sounds and make sure we're not overloading them. These kids still may need that 60 per kilo bolus, but we're going to give it to them 5 to 10 mLs at a time, and then reassess. Other things to do, obviously, we've kind of talked about that. Head of the bed being up, especially if they have that fluid problem, we can help move that fluid and help with their breathing. These are the things we want to look at to make sure we're not doing this to the patient with those fluid boluses. Obstructive shock. Most of the time when I think of this, I think of it as being a trauma to the patient. Something's going on and we can't. Seen a few kids that have had spontaneous pneumothorax. Those patients are typically teenagers, male, who've had really big growth spurts and are super tall. Your traditional trauma should be understanding. So I think if we have a chest that's down, most people will know what to do. Follow your local guidelines. I will tell you this, in the smaller kids, babies, at Children's, we're going to the anterior axillary line most of the time. If you watch football, you'll know that if you stick a needle in someone's back, evidently you can drop a lung. So, with our penetrating chest traumas, or trauma to any type of the heart, even thinking post-surgery, we can start to get cardiac tamponade. Your good old Beck's triad of hypotension, JVD, muffled heart sounds, pulsus paradoxus, and narrowing pulse pressures are what we're looking for. You may temporarily get some improvement, and this is where I said I wasn't going to talk about Starling's law until later. And this is from Starling's. We're going to give the patient a little bit of fluid, and it's going to increase that heart's ability to expand and give us a little bit better of a kick. It's a very delicate process because once we go too far, we'll put them into overload because they're not going to be able to move that fluid around the body. So just judiciously administer those fluids. Probably sit this patient up and have them lean forward a little bit, getting that fluid off of from pushing down on the heart. Laying them down will probably cause this to be worse. And then your type of infections. So some sort of infection can cause us to build up things. So if you get a central line, gets a clot built up on it, if we have any other type of clotting going on. Teenage girls who have been on long airline flights and haven't gotten up and moved around. That's one I've seen where they've thrown a PE. Your typical PE presentation. They're going to end up needing anticoagulants, and these patients will also want to be upright. So how do we assess these patients? The good old pediatric assessment triangle. It's what we're going to do from the door. We're going to look at their appearance. Does this patient appear to be okay? And I did not know that TICKLES was an acronym until last week when I was at an ER education day. So you're going to look for tone, interactiveness, consolability, look, gaze, speech, cry. If you walk in and you see that kid who is going to be blue and limp and has some sort of abnormal sounds breathing, that's going to be a huge, I need to go right now and do something. This should only take your first 30 or 60 seconds. This shouldn't be very long. When it comes to our breathing and our skin color, those sometimes you may need to investigate a little more. If you have a patient who's in anaphylaxis, you may need to remove their clothes so that you can actually see any type of rash. Again, your ABCDE. One thing about the ABCDE as a ITLS instructor, if you have extenuating bleeding, please address the bleeding as soon as possible, because if they bleed out, the rest of it's not going to happen. Get IVIO access as soon as possible. So what do we do the rest of the time? How are we going to treat these patients? High flow O2 or intubation if needed. If you have a kid who's in DKA and they have been just breathing away at 40 times a minute for 5 or 6 hours, that patient probably isn't going to be able to keep that up for very long. And you're going to need to think about, how long is my transport time to get to somewhere where they can actually do it? Can I manage this patient with a BVM, BiPAP, CPAP, something of those natures? And you need to make sure that you have everything you're going to need to do it. Just remember, when you're looking at the end title, to correlate it with your patient's condition or suspected condition. Fluids, literature goes back and forth on saline, lactated ringers, depends on who you look at, which study you're choosing from. But your standard dose is here. And then your cardiac dose is there. Big important thing that you do is reassess after every bolus. Make sure your patients aren't going into fluid overload. So I've already talked about this. I'm not going to belabor it anymore. The goal of all of this is to restore perfusion, not just get their blood pressure up. We need to make the heart rate, cap refill, and level of consciousness better, because that'll tell us more than their blood pressure. Especially if these kids are compensating, we may already have the heart rate and cap refill being compromised, or the level of consciousness. So some fluid calculation tips. Your standard bolus is there, but good old Roslo tape. I know that there's departments out there who are using Handtevi app. Whatever it is that you guys are using for it, I encourage you to. There's great things in that information. Both of them are pretty much going to give you the similar answers. Just document what way you estimated their weight. So for those of us that are remembering the older way of doing an IO, if you can't get an IV in 90 seconds, or if you can't get it in 2 attempts, you should be moving on to the IO. Multiple hospitals that I've worked in, when it comes to starting an IV on a kid, they will stick these kids 5 or 6 times before somebody's willing to say, let's give them an IO. The one I'm most familiar with now is the Easy IO. Not a sales pitch for them, but just as a way of pointing it out. I'm pretty sure the SAM has similar size needles. But these needles are all 15 gauge. So if you have a baby and you're trying to start an IV on them, typically, if you're having a good day, maybe you get a 20 in them. Well, how easy is it to push a fluid bolus and code a patient through a 20 gauge, God forbid a 22 or a 24. So if you can put in an IO, you will probably have much better luck at getting, especially a fluid bolus, in quicker. By no means am I teaching you IOs today. This is just an awareness. Follow your department's guidelines for it and being checked off. Here's some reasons to do it. There are contraindications. My favorite is a prosthesis, so please don't put this in someone's leg if it's not a real leg. I'm pretty sure they're talking about if they have some sort of knee surgery. At Children's, if there was a kid around who had knee surgery and had some sort of artificial hardware in there, that would, they'd come there. We don't want to go through an infection, and if there's been an attempt in the last 24 to 48 hours in that bone, we don't want to use it. If the bone is fractured, we don't want to use that bone. I probably wouldn't use a tibia if there was a femur fracture, because it's just going to cause your fluid to end up sitting in that leg. So you may want to switch to another site. Here are our sites. I will tell you that the tibial tuberosity, when they gave us the easy IOs as medics, we ended up having like an 80% success rate using it. Easy to find, nice flat spot. Just make sure you're not holding behind it, especially if you're using it on a baby. Grab down around the ankle, and you can externally rotate the foot, and it gives you a nice purchase point to insert the IO. Humeral head requires a specific setup to get them. Just remember, you either need to put their arm across their chest, or you need to internally rotate it so that their thumb is pointed out and their back of their hand is against their hip. You're trying to get the brachial tendon away from the site so that you can get there. It cannot be used until kids have reached adolescence. Now, we have some big kids around here who are 12, 13 years old and 200 pounds, so you might have to just use your best judgment on that one. But follow your local protocol. So, placement. I think everybody should know. There used to be the teaching of we would aspirate back marrow. Teleflex did a study, and there's some really good videos out there if you're into it from the Teleflex themselves. But the study showed that of successfully placed IOs, only 30% would get aspirate back. So we would not use an IO because we didn't get any aspirate back. And if we would have just flushed it and seen if we had any dependent pooling or any leaking coming back from the IO site, we would have been able to use that because it would have worked just fine. You can pressure bag through this. The push-pull technique, which we're talking about here, is something that I did not know until I started working at Children's. And it's misnamed because you're going to pull the fluid off first, and then you're going to push it through. So, sorry the picture is grainy. You're going to have your fluid set up on your tubing, stopcock at the end, extension set going to your patient. You're going to use a 20, 30, 60 ml syringe. You're going to turn it off to the patient, open it to the bag, pull up that fluid off to the bag, and push it into your patient. I like to use a 20 ml syringe if I'm going to do this because the math's simple. I give a 20 ml bolus, so whatever their weight is, that's how many times I push this. This gives us a very accurate way to administer fluids to a pediatric patient. Now then, if you have a kid that's the size of an adult and you're going to end up giving them a liter, different story. But if you're only going to give 200, you do this 10 times and you've given that very accurate. Patients that I've seen in the NICU, they've even used 10 ml flushes to administer the fluid boluses for them. If you are putting these in a conscious patient, and I will speak from experience, they will not like it. It will work great. However, the second you go to flush it, that is when they're going to, if they're conscious, rip off every piece of monitoring equipment you have because they're going to thrash around. The lidocaine going in will numb it, but you have to let it sit. So remember, it needs to sit for about 2 minutes. Check with your protocol and make sure that you follow whatever they are recommending. So some common pitfalls. The BP is normal, so this kid is fine. Just remember that the kid's BP will continue to look good as long as that tachycardia is going on. So we want to look for the tachycardia, the cap refill, changes to the skin, and the altered mental status. Our medical director for air evac, if you have a patient who has the potential to be in a shock state and is tachycardic, he wants us to be treating that patient like they are in some kind of shock and start working on it. People wanting to delay going to the IO. Like I said, for some reason in hospitals, they want to keep sticking, and then they call vascular access, or they wait for the physician to do a central line. We can do an IO once we have that stuff, probably in 30 seconds or less, and be using it. So if you're in a situation and somebody maybe forgets or is not willing, make the suggestion. They only want to give a little bit because they want to see what happens. If you're going to give a fluid bolus, give a fluid bolus. If they're in shock, they're going to need it. Now, we can, if you're concerned about giving them a 20 ml per kilo, well, when you get to that 10, give them a quick listen. If they're still fine, continue. But don't withhold the entire fluids just because you're concerned that you may put them in overload. Do your reassessments. Only giving one fluid bolus, another. These kids, especially in sepsis, may need that ton of fluid volume. You can't treat all the shocks the same. We can't treat cardiogenic shock the same as we treat hypovolemic, and we can't treat obstructive shock the way we would treat distributive. So try and figure out which shock you're in and treat them appropriately. Please, 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 this is where the ER nurse in me comes out. I will tell you that calling ahead will make things go smoother for your handoff. Not the best segue in the world, but speaking of the handoff, and what good EMS lecture doesn't cover documentation? So make sure you're noting the time that this all started. When did this shock state start, if we can determine it? Do vitals, but then do serial vitals. Keep doing the vitals, and depending on how unstable your patient is, you may do those every 3 to 5 minutes to make sure that you're getting it right. If you can't get a blood pressure on your monitor, please do one manually, because that's going to give you that extra data point. Make sure you're telling them exactly how much fluid you gave. Don't write bolus given. If you're giving multiple, and note the time, and if there was a change, if there was an improvement or no improvement. So I was taught the chart when I was going through medic school, but nurses like SBAR. So that's why I put this on here for when you're giving your hospital notification. I know there are other acronyms out there, but this is the one that they taught us in nursing school, so I put it on here. It gives the nurse a very systematic approach to things. I will tell you this, if you call the hospital and you need a physician's order, please start that off with, this is whatever unit, I need to speak to a physician. That way we get you to the right person, so we're getting you orders when you need them. All right, I have a couple of case studies here. Some things to think about. You have a 4-year-old male. Patient reports 3 days of severe diarrhea and vomiting. Child has not urinated in 12 hours, is not acting right, no fever, no known medical conditions. If anybody wants to drop in the chat, by all means, tell me what you're thinking with this patient. Where would we classify this patient? What kind of shock are they in? What would we do immediately? And how much fluid would you give them initially? Those are the things that I'd be thinking. The child's awake but irritable, and you can't console them. They're pale, and there's no increased work of breathing. Heart rate's definitely up. Respiratory rate's up. Blood pressure is probably normal for a 4-year-old. So the vitals aren't all of that crazy. Dry mucous membranes, sunken eyes, right? This all points to they're dry. And Vogel Pool, thank you for playing along. You're right, hypovolemia, loss of fluids due to something going on here. So here we are. This is the treatments that I kind of threw out there. Putting them on some oxygen just because of the shock, and then going ahead and giving them, fluids for them, and then we reassess. Well, reassess, and they're still. So we're going to probably do another bolus, right? And we're getting improvement from these boluses. It's just not jumping very far. But here's the one that stood out to me. They're more alert and they're consolable. Well, that's a big change in mental status. So I don't know if this patient's an emergent patient. I'd probably just go non-emergency to the hospital with them. Case study 2, 8-month-old, fever, won't wake up. Report fever for 2 days, Tylenol not helping. Decreased feeding and fewer wet diapers. Child developed a rash and became floppy. Well, barely responsive to painful stimuli, that would definitely kick up mine. Scattered petechiae, and the breathing appears rapid and shallow. None of these vitals look good. And weak central pulses, 5 on the cap refill. I would not be very thrilled with this. So yeah, Josh, meningitis is probably what we're going to expect here with that petechial rash. That's the clue. We are definitely going to put this patient on high flow O2 and bag them. If you're not ALS, for our EMTs that may be out there, get ALS moving. And this infant is probably close to going off the edge of that cliff. I don't think, 8 kilos. I don't know how many people are going to feel confident about getting an IV in an 8-kilo kid whose blood pressure is super crappy. I would probably go to the IO quickly on this child. If you need orders for something, make sure you're doing those early. So you give a bolus, we get some slight improvement. You give another bolus, some slight improvement. I would probably go to the third. And as soon as I got to the hospital, I would tell them, hey, they've already gotten 3 fluid boluses, or call and ask for some sort of order for a pressor. So this kid would end up probably receiving 40 per kilo in the first 15 minutes and still need more. So some things to take with you. Kind of hit these points over and over again, but this is what you should probably think about. If you ever have a child who's in a shock state, what we're looking for, go to that IO early with these kids because it's going to help you in the long run. Cardiac kids, lower bolus. And then don't be afraid of fluid resuscitation. If that kid needs the fluid, give them the fluid. Tony, you said make it about an hour. I left time for questions if anybody had any. I'll be glad to answer them. If not, I hope you all have a Merry Christmas and a Happy New Year and stay safe out there.
Thank you, Chris. Thank you very much. Yeah, we're about an hour in, and if anybody's got any questions, please feel free to reach out. We don't answer them now, we'll get them answered. When Chris talks about using IOs, they're a great resource. Make sure you're securing it. And if you use the shoulder, make sure that you are securing the hands. I saw a neat little uh, show, and they were showing a couple of the IOs that they removed from uh, people's shoulder, and they were bent because the arm wasn't secure. So if you're using the Lucas device, it comes with those handcuff kind of things. If you're um, not using the Lucas, you still want to secure the hands together. Even if you just take some tape and tape their thumbs together to prevent that movement of the arm. Uh, they all come with a securing device. Those help, but make sure you're securing the legs or the arms properly when you use an IO. I don't know if Chris, if you've seen anything
Yeah,
in the
Tony.
ER.
Um, I've flown patients into the trauma centers, and the first thing the trauma nurses want to do is flip that arm out because they think they can get an IV better than we can. And they won't pay attention to that pink band on the arm or the IO sticking out of that shoulder, and they'll roll that over to go for the AC, and they've now dislodged your humeral IO. Use the pink band. I take cravats and tie them in such a knot that somebody is going to have to cut the cravat off of the patient's wrists. And I will tell you, the problem with the Lucas is when we go to take their arms down, if somebody doesn't say, hey, there's an IO in the shoulder, and we don't do it in a careful fashion, we can dislodge it. The only other problem I've had with IOs, and it was more the hand ones where I saw were bent, is just be cognizant of your placement of them. If you think you're going to be giving a patient something that has a short half-life, the humeral head is the best spot to go because it's almost central access. Teleflex has a video of a cadaver cut down where they push fluids and you see that subclavian immediately swell up as the fluids go through. Really cool stuff as long as you're doing it from the medical ones, not just stupid people playing with IOs. There's great videos out there.
Cool. Thank you. All right. I'm going to say that's about it for the day. Our next class will start in January. Josh is going to go over some interesting OB runs that have come in uh, through the past year. He's got a couple of really good case studies with some neat outcomes and some really good EMS care and some points to really remember um, when we're taking care of mom and baby. And other than that, thank you, and we will see you next month. I'll send out my regular invite and hope to continue this next year. We've got quite a few lined up already. Thank you.